considerations, especially, you know, things that you might see in the future. But we'll start with really just the basics on our initial patient presentation, kind of like we did before. So you got a 22-year-old female brought to the emergency department by paramedics after being involved in a high-speed motor vehicle crash into a tree when her car veered off the highway. What do we want to know most importantly with these motor vehicle accidents? Yeah, seatbelts, were they restrained? Where were they in the car? Did the airbags deploy? And then we'd also like to know if there's any fatalities at the scene as well. That usually helps us with mechanism of like the speed, because everybody says they're going like 50. I think that everybody like 50. But we do want to separate like whether it's highway speeds, whether they're stopped at a stoplight and somebody rear-ended them. So all of those can help us with how significant those injuries may or may not be when we're evaluating them based on history. And then, you know, we do like to know, you know, if there was any extrication, how long it took. Nowadays, EMS even takes like pictures, really bad ones, and they're like, oh man, look at where we had to extricate them from. And you're like, oh, yep, they're getting everything, pan scan. But we also want to consider our missed as well, so we want to get that EMS report from those patients. So what was the mechanism, injuries, you know, symptoms, signs, vital signs, treatment. Those are always important. All right, so she fell asleep at the wheel when this happened. She was restrained, and the front side airbags were deployed during the crash. What do we think for this? Like, obviously we don't have a patient in front of us, but just based on this history, what are some of the concerns we have? Everything, right? Does she have any chest injuries? Does she have belly trauma? What if she was just wearing a lap belt? What would we be worried about? You know, like chance fractures or what else? Like that multiple-discus injury, right? All right. So in the ED, blood pressure 100 over 80. Is that good? Bad? Kind of like, what do you think? Yeah, it's okay. Yeah. Sometimes we use the word like tenuous. They're kind of like in between. This one would be like a tenuous vital signs, you know, 114. So she's tachy, but not like, you know, 140s or 130. Tachypnic, GCS 14, O2's 92 on 4 liters, nasal cannula. So on your primary survey, airways intact, you know, diminished breath sound to the left, chest wall tenderness, subacute emphysema. Over the left anterior lateral chest wall, heart sounds are normal, no JVT. So what do we need to do during our primary survey for this patient? Yeah, probably need to get a fast exam, right? We want to take a look at that belly, we want to look at pericardium, make sure we don't have effusion. So we want to make sure there's no bleeding. What do we think, what sort of treatment do we think she's going to get right now, based on this? Yeah, probably got a tension pneumo or a pneumothorax, so probably going to get a chest tube, good. What about this chest wall tenderness? What else do we think? Yeah, rib fractures, and then you have that, like I said, that air over there, especially when you see on the x-rays, can be a subtle indicator if there's no significant pneumothorax on there that they might have something else going on that you might be overlooking, so it's always important to evaluate that subacute emphysema. What if she had like distended neck veins and tachypnic at like 44 a minute, like tracheal deviation, what would we do? Yeah, thoracotomy. Like they're gonna, or thoracostomy, sorry. Yeah, they're gonna need a chest tube like stat versus a more stable patient. Like this patient right now, probably, you know, we can get the x-ray before we put the chest tube in based on this presentation. All right, so the secondary survey is unremarkable. And then here's the chest x-ray, what do we see? You're like, crap, I don't have a positive arrow sign. So, pneumothorax? On the right. Where? don't know. What do we see different on the left here and the right? Like in the apexes. Like it looks like maybe a visceral pleural line, right? You guys see that? Like I said, x-rays, we think they're like easy, but a lot of times these like smaller pneumothoraxes can present like very subtly on your x-rays and can be missed. So yeah, up here we got that. What else do we see?
Really deep salts.
I mean, or it could be a normal sulcus and the left is abnormal. Yeah, you got like some blood in there, so probably some fluid. What do you see right above that? Like, big old fracture. And then there's another one. Here, I got some positive arrow signs. There we go. A little bit of wide mediastinum as well. And then you got your pneumothorax on there. So that's why we like to read the x-rays in that, in that fashion. More of our A, B, C, D, E, F, Gs when we're looking at these. So it's important to, evaluate them the same way every time and look at everything on these chest x-rays. So what is this patient going to need? Yeah, this patient's going to need a chest tube. Yeah. You guys see a pulmonary contusion on there too? See kind of lightened? Yeah, there's a pulmonary contusion as well. And then, the mediastinum's lightened, so we have a concern for some sort of aortic injury as well.
Sir, can you cut that light off in front so we can see it?
Yeah, the lights, that one light's still kind of causing some issues there. And obviously on the test, we like to do like blurry x-rays that are a lot harder to read. All right, so she's gonna get a chest tube. What are some of the principles of like chest tube insertion that we like to use to avoid iatrogenic injury? She's always like, yep, over the rib, so we avoid that neurovascular bundle, good. And then we like to do that finger sweep, the 360 finger sweep to ensure that, we don't have any adhesions in the lung and that we're actually in the correct place. And then we like to have a controlled pleural entry while we place that. So you got that little bit wide mediastinum. What's going to be your initial study of choice that you want to evaluate that with? Yep. CT angio? Yep, that's going. So if patient's stable, CT angio. What else do you want to look at just based on some of it, like where the fracture pattern is, but also thinking about, the location of the injury and what part of the heart is closest to there. So probably want that fast for looking for that effusion as well. All right. So obviously, what are the diagnoses in this patient? Got rib fracture, pneumothorax. Would you say there's a hemothorax there? We have some fluid down there, and it takes usually like 300 milliliters to start blunting that CTA. So, yeah, probably hemothorax, rib fractures, pulmonary contusion. And then we want to think about if they're stable, it's that CT angio immediately to rule out any sort of aortic injury. What kind of treatment, if we suspect an aortic injury, do we want to give them? Yeah, beta blockers. Yep, good. All right, so like we talked about, considerations, obviously our ABCs are most important, especially in this patient. We had that diminished lung sounds on the left side. They were, kind of tenuous vital signs, so tachy, tachypnic, but was still, wasn't hypotensive. So obviously we're getting, IV fluids, possibly blood. We want to get all the labs on them, and then obviously oxygen vital signs, getting that left tube thoracostomy. She's going to get frequent reassessments. And then any worsening, we're going to look at taking that airway or securing that airway, and then we move on to our imaging studies, which likely we can in this patient because typically, a chest tube can be treated in the emergency, in the trauma room. You can place a chest tube, and that will likely stabilize this patient. enough, especially with a little bit of fluids, that you can then get all your imaging. What kind of imaging do you guys want on this patient? Like pan scan? You want like CT head? What? Six pack. I don't know what that means, but I'm assuming that's everything. I'm gonna go with everything. So CT, head, neck, chest, abdomen, pelvis. Alright. So obviously, like we said, we want to understand that mechanism, so that amount of energy that they may have sustained during that crash or that one trauma. And then obviously, our approach to chest trauma is, you know, relatively simpler compared to other body systems, just because you can, you know, you can see a tension pneumothorax based on their objective findings, like their vital signs and your physical exam, and we can treat those emergently in the trauma room and hopefully fix whatever that problem is. What if you got like, you know, you got a lot of drainage from the tube? What are your indications for a thoracotomy? Well, yeah, the vital signs go away, yes. How much drainage from that chest tube would you consider to need a thoracotomy? Or yeah, over 1,500 milliliters. And how many milliliters an hour would concern you? Yeah, over 200. Good. All right, what do we do for the rib fractures? Yeah. What are the like initial considerations we do? What's that? Flail chest, let's say. Yeah, I mean, we'll manage them with pain control usually first. And then we don't operate on most of those flail chests, so they'll typically have a trial on the, like on the ICU with pain management, and then just monitoring their respiratory status throughout. If they're going in the chest for another reason, they might do a fixation of those ribs, but typically we manage them non-operatively. And then, how does a pulmonary contusion affect their respirations? It has, like, what one of the terms used is like VQ mismatch, but it has a ventilation perfusion mismatch, which produces like that intrapulmonary left to right shunt, which leads to hypoxia. So we really, we really want to give them some oxygen on those patients. And then what's our treatment for tamponade? Yeah. What's our temporizing treatment? Yeah, and then more definitive. Yeah, it's a sternotomy window. What's that? Okay. Well, a lot of them aren't saying answers, I'm just saying them. So I'm repeating myself most of the time. I'm just kidding. Sometimes it's hard to hear up here. Yeah, I'll make sure I repeat those. And then we'd already talked about CT angio if we're worried about any of that traumatic rupture of the aorta. All right. Got a 36-year-old brought from motor vehicle crash, unconscious, intubated in the field. Soon after intubation, becomes hypertensive, noted to have diminished right breath sounds, leading to right needle thoracostomy, but improved his blood pressure. The ED has extensive subacute emphysema in the neck, throughout the entire chest, moderate amount of blood in the tube, endotracheal tube, so we place a large bore chest tube on the right side. Subsequent chest x-ray reveals a large right pneumothorax. The proper chest tube positioning patient now has a large amount of air leak in the right chest. O2 is 89%, there's SpO2. So what are we worried about at this point? What do we think we need to do? This one can be a little complicated, right? No, we typically don't place more than one if we have correct placement of our initial one. Well, a bronchoscopy could help, but we're in the acute setting, like the emergent setting. A bronch is typically later in a hospital stay. It's not something we typically do emergently. So this patient probably has some sort of like tracheobronchial injury because we have, correct chest tube placement, and, we are assuming on here, I guess you could argue, like, well, you didn't say whether it's in, whether there's some sort of leakage in the pleurovac or the tape or whatever, something in the tube is clogged. But the concern here is like a tracheobronchial injury, so we'll typically do a thoracotomy on them, and this one would just be a right-sided thoracotomy for this patient. All right, here's another one, 32-year-old, another automobile crash. He had witness Bouts emesis. They intubated him at the time of his arrival. Pulse 78, blood pressure 174, GCS 8T. What's the T mean? He's tubed, right? Yeah, 8 tube. So he's intubated. Breath sounds are diminished on the left. Chest X-ray in the emergency department revealed opacification of the left hemithorax with shifting of the mediastinum on the left. Which of the following is best treatment for this condition? This is an important question, actually. This is very easily fixed and common. D, everybody agrees D. Why? For those that may not be medical before, what are we worried about here? Yeah, we're worried about the tube, right? It's a right main stem tube. So basically we place the tube too deep when we intubate it. So typically it's like 23 at the teeth is common in adults. So that's something we need to look at. Sometimes that tube may have shifted down when you're doing all these other procedures on patients. So like if they were getting, a chest tube and we're moving them around and rolling them, sometimes that tube may not have been secured appropriately. It could have migrated lower. However, I always worry when something was placed in the field that it's in the correct position. So that's why, like I said during the when we did our trauma scenarios, like whenever anybody comes in intubated, we want to check that tube and we want to visualize that it goes through the vocal cord. So we'll place a laryngoscope in their mouth and look and visualize. And then the other problem that we see is we have to adjust that depth because it's right main stem. So it's a very easy fix. So, sometimes we'll get confused and see that opacification in the lung and think they have some sort of injury there. And our initial instinct is, oh, we need to throw a chest tube. When really we just need to back the tube out. All right, what do we see on this chest X-ray? What's going on that left side? Maybe? Yeah, could be no arrow. What do we think's wrong on this one? What do we do for this patient? Chest tube? Is that what we're saying? Chest tube? So this is the same patient in the last question. So this is a right main stem bronchus intubation. So pay attention to where your tube is, and you see how it's kind of angling to the right side there. We want it right at the carina, which is up here. I think I see it there. It's kind of opacified here. But this is what it looks like when we right main stem somebody. So it can confuse you, and it kind of looks like fluid in that chest, and we need to put a chest tube in. So just, be cognizant of everything when you're evaluating that patient. You want to look at where that tube is located, especially at the teeth. So that patient was probably like 33 at the teeth, which is a little deep. Actually, I don't even know if it goes to 33. Maybe it does. All right, let's talk about another one. All right. So you got a 23-year-old restrained driver, high speed, head-on collision with an 18-wheeler, drifted across the highway divider. So what do we want to know? Yeah, is he alive? Does he have a pulse? Good, bring him to the hospital. So obviously any fatalities at the scene. Since the 18-wheeler hit him, I would assume he would have been the fatality, but you also want to think about anybody else in the vehicle. Typically, these are very bad accidents, and they require prolonged extrication sometimes. But it's important, like we get, any fatalities. Obviously, it says he's restrained, airbag deployed, but whether the airbag deployed, what were the vital signs on scene? Is he alive? And then our missed report, obviously we got the mechanism, but what injuries do they have after they extricated him? What have they done for treatment and symptoms, vital signs? All right, so according to the paramedics, front seat passenger in patient's vehicle was found dead at the scene. Extrication was 30 minutes. Vital signs are stable, unstable. Probably call that unstable, right? I mean, tachycardia, tachypnea, blood pressure is soft. It's hypotensive, and the GCS is 6, so they tubed them, put peripheral IVs. Hopefully they put a C collar on them, right? That's probably something important that wasn't mentioned there. All right. So what do we do here when they arrive? ABCs, right? ABC. All right, so obviously, we want to know what physical exam findings we have. Obviously, everything, right? Like how does his chest look? How is, is his pelvis stable? How the breath sounds? So that's why we do our ABCDEs. This is obviously going to be probably a polytrauma patient. We think probably TBI as well based on his GCS score. Other considerations like does he have a seatbelt sign, steering wheel sign? What is the most common solid organ injury that these patients face? Yeah, liver, right? So let's say everything ends up being stable. We have a grade 4 liver laceration. We monitor him throughout the hospital and then we discharge him. When would we recommend imaging for follow-up? What time frame after discharge do we normally re-image these patients? Yeah, 4 to 8 weeks after discharge. All right, so here's we already gave vital signs, but we have vital signs on the scene. So at the hospital, it looks like he's pretty sick, right? He's even more hypotensive, more tachycardic, tachypnic now. GCS is now 6T. So yeah, we have a forehead hematoma, laceration, multiple facial wax. So there's a concern for some sort of facial fractures based on this presentation. What sort of signs might we see on our HENT exam of skull fractures? Yeah, battle signs recognized, hemotympanum, those are all things we need to look at. Any sort of CSF from the nares. And then the breast sounds wraps on the left, so obviously some sort of, pneumothorax on the left side. The abdomen's distended with absent bowel sounds. So fast exam is going to be important on this one, on whether we need to take him to the OR. And likely they do. What sort of fluids would we want to give this patient? Blood. Yep. So based on his GCS vitals, do we think that this is caused from his traumatic brain injury that his vital sign? Yeah, so there's blunt trauma, so we most likely not. So we want to get this patient blood and resuscitate him because we want to avoid that hypotension and any hypoxia in this patient. All right. So like we talked about here, so he has he probably has a left pneumothorax. We got facial fractures and he's concerned for traumatic brain injury, and then there's a left femur fracture as well. So he's going to need some blood products. And then we have that concern. We didn't give you a fast exam result, but there's concern for some sort of bleeding intra-abdominally on this patient. So likely tension pneumothorax based on the vital signs, so we need to get a chest tube in, chest x-ray fast. And then a pelvic film as well, just based on the mechanism, even though the pelvis was stable. We do have signs of shock, so we need a lot of blood talked about, like ABCs, obviously what's our history of the traumatic event, obviously they had a fatality in the vehicles that raised our suspicion that pretty significant mechanism of injury. He's got a TBI, but like I said, it's rarely the cause of hypotension or hemodynamic instability alone, so there's probably something else going on based on this presentation. And, you know, his vital signs from EMS were kind of like, you know, he was borderline hypotensive, a little bit tachycardic, a little bit, I don't think he was tachypneic. So, shock can cause inadequate brain perfusion, so sometimes that GCS can be declined just because of hemodynamic instability in the patient. I mean, obviously he has facial fracture, so we're concerned that he has TBI as well. Alright. Which of the following statements is accurate regarding the use of PAM-CT scanning? Yeah, C, right. So, brain, C spine, chest, abdomen, and pelvis. But it's six-pack mainly, somebody said that. I got 5 of them. Okay. Okay. I'll buy it. He said contrast head and non-con head. I would argue contrast head and neck, especially for this. Especially if a restrained driver could have some sort of cerebral vascular injury there. Alright. Which of the following factors is most likely to contribute to worse outcome in patient left subneural hematoma and a GCS and die? We agree, A. Like we talked about, any sort of hypotension can increase morbidity and mortality in these patients, as well as hypoxia. So those are some of our biggest concerns. Those secondary brain injuries can lead to a worse neurologic outcome if they survive. So we always want to basically and normal everything. So clean it, normal intensive, that's our goal. Alright, so we got a 32-year-old struck by a large branch that broke off the tree, hit the patient on the right side of the head and the right chest. Large right parietal scalp hematoma, right cheek deformity, right chest wall deformity, absent right side of breast sounds, pulse is 110, blood pressure 120/70, breast curves at 30, GCS 13, which is the most appropriate next step. I heard CT, and he's tachycardic, tachypneic, and he's got absent right side of breast sounds. What should we do before the CT? Yeah, we should do the fast before that too, but we should place a chest tube, right? We got absent right side of breast sounds, and he's probably got tension physiology because he's tachycardic and tachypneic. He's still maintaining his blood pressure. And then his GCS 13. So we'll eventually get CT. Oh, we got more. Alright, we got a 40-year-old unrestrained man was driver of a car, crashed into a tree. Car apparently veered off the road, brought to the emergency department. Found they had multiple superficial scalp flex, left subdural, no midline shift, GCS 14, 60% left pneumothorax with no non-chest X-ray, left tibia and fib fractures, which are just left pedal pulse stenoid. What sequence or priority are we going to treat this patient with? C, A. What's our reasoning here? So what's going to kill him immediately? Well, a brain injury can't kill him immediately. If you made it to the hospital, he'd probably been dead at scene if it was that significant of a brain injury. What is going to be like our most important consideration we can fix right now? Would probably be what we look at first, and it's less invasive Dunmore. 73-year-old, fell down a flight of stairs, on the backboard seat collar, pulse 70, blood pressure 160/80, respiratory 10, GCS is 6, large scalp hematoma, dilated non-reactive left pupil, large bruise over the left flank. So what's the most appropriate treatment for this one? What's our number one priority right now? Just going back to our primary survey. Yeah, we need to tube him, right? So this one's going to be E. He's going to need to be intubated, IV fluids, fast exam. Then likely, if he's demonstrated stability, CT the brain and neurosurgical consultation. But we do also have that like left flank bruising. So he's otherwise stable, so likely, we're not suspecting some sort of intra-abdominal bleed, but it is something we need to consider on this patient. But the priority would probably be his brain right now, since we don't have any demonstrated signs of bleeding. But we probably get a pan CT as well on this patient if we're going for the brain. All right, I got another one. Sounds are present equal bilaterally. What is our next step? So he's stable. What imaging do you want? Yeah. What can we do before that? Yeah, fast and a chest X-ray. We always got to do. That's why we do our primary surveys, and every time we typically get that chest X-ray. There is concern. I mean, is there concern where that stab wound is that it might be in the thoracic cavity? Yeah, right. It's 1 centimeter above the left costal margin. So we have to worry about intra-abdominal and possibly intrathoracic injury. Good. All right, so considerations here, like obviously if they remain stable, no immediate indications for surgery on this patient. So we have a couple options here. Supposing that the chest X-ray is normal, we don't suspect any intrathoracic injuries, and our fast is normal, so we can typically manage them with further imaging and a CT scan. So if the CT scan doesn't show any like fascial penetration on their intra-abdominal injury, what can we do at that point? We can monitor. We're definitely going to monitor them. The CT is not 100% diagnostic, so we likely want to expand those lacerations and evaluate whether it actually penetrated the fascia or not. And if it didn't, obviously we can just monitor them and observe, and then likely eventually discharge them. If it did, then they're going to go for that X-lap. If it penetrated the fascia, we need to visualize it there. Now, if we don't want to expand those wounds, or it's not indicated at the time, we can also do a diagnostic laparoscopy later on to verify if the patient is stable. We have equivocal CT imaging. We may consider that diagnostic laparoscopy. And then once again, like if it did penetrate only the liver or some of those other organs, we typically will manage them not a lot based on the CT scan results and how high of a grade those injuries are. All right. So, we used to do laparotomies for everybody. We obviously don't do that anymore. We typically reserve those for anybody in shock, or if they have like overt peritonitis, or we see some sort of evisceration, impaled objects still in there, we're likely going to take them there. We don't do the diagnostic peritoneal lavage anymore, but I mean, it is still something they teach, because I guess someday if you're on some far off battlefield, you don't have a CT, you don't have a ultrasound, but somehow you have TPL equipment, I guess, maybe we're going to do that. Yeah, fast sometimes isn't as accurate for those retroperitoneal injuries or bleeds, and it may not be evident initially. I think we talked about some of the other stuff there, and then it also has on there, like they did do a fast study looking at missed injury rates. So 17% missed injury rate was reported. I actually thought that missed injury rate would be a lot higher, honestly. That's actually pretty good. I mean, it's not good enough to discharge somebody if the fast is negative, but it's definitely, has a better sensitivity and specificity. They were probably really well trained physicians doing that. And then obviously we do damage control resuscitation for that lethal triad. Don't worry, we're almost done. Alright, so you got 25-year-old stabbed in the abdomen, 2 centimeters above the umbilicus. Are his vital signs stable? Probably. Let me pull it back. Well, probably consider that unstable. Stab wound's not bleeding, but the abdomen's rigid and tender, diffusely. What are we going to do for this guy? X-lap. Yep. Alright, don't worry, we're almost done. I'm going fast. 18-year-old, he's stabbed, left upper quadrant of the abdomen. Minimal pain, alert, hemodynamically stable. Abdomen exam is essentially normal, minus a stab wound in it. Which of the following statements is true? What's that? The correct answer is E on this one. So C could be true, however, which one is definitively true, and that's that, focal wound exploration reveals no fascial penetration in the patient, should be admitted for clinical observation. All right, last one. 33-year-old woman. That's it. Now we got a woman that's stabbed. Changed it up a little on you. Right anterior axillary line, 3 centimeters superior to the right causal margin. Alert. Normal mentation, airway intact. Blood pressure 186/60. Heart rate 100. What's the most appropriate next step in this patient? What do y'all think? Yeah, we went very simple on this one. Listen to the breath sounds. It's going to be our first priority. So once again, back to our A, B, C, D, E, F, G. No, it's just A, B, C, D, E, according to the advanced trauma lives. All right. Oh, I lied. Last one. Sorry, we're only 1 minute over. 22-year-old man presents single stab wound to epigastrium. Patient's diaphoretic, somnolent, pulse 120, pressure 80/60. Respers are 8, that's not good. GCSA, single stab wound, 6 centimeters below the xiphoid. Chest x-ray does not demonstrate evidence of hemorrhagic. Fast demonstrates free fluid in the pericardial space, free fluid in the subhepatic space. What's the best next step, I imagine, in this patient? Do we say C? No? D? What did we say? This one, I mean, if you're looking at where that location is, we don't know how large of a knife it was or stab wound on this. So we have to consider some sort of like intrathoracic injury as well. So like really, you got free fluid in the pericardial space, so likely pericardial effusion, and then we got free fluid in so we do have a belly bleed and we have pericardial effusion. So the question is, this patient is unstable. They're probably going to get an exploratory laparotomy. That's not wrong. But we also need to treat that pericardial effusion. So they'll probably get both, the median sternotomy, X-lap. Technically, D was supposed to be the right answer, but you could argue both those in this question. I think they're both right. All right. That's all I got, guys. I'll see y'all at the lab.